Thank you, George. Thank you for the invitation, and thank you for your friendship, and thank all the Greek friends, especially for you, for Petros, for George Karatasakis, Mitris Tsiapras, for the continuous support and friendship, which I very appreciated. And I'm very deeply sorry that I cannot be there, but maybe next time. And hopefully we will meet in the next future. I don't know if it is my presentation visible now.
Okay, we see it.
It's okay. Then, as all we know, degenerative aortic stenosis is the most frequently diagnosed heart valve disease in Europe and North America and in the world. It's a chronic and progressive disease. Currently, the predominant cause of aortic valve stenosis is the degeneration and the calcinosis of the aortic valve. Historically, it has been considered as a consequence of a long-term wear and age-related degeneration of the valves. The calcinosis of the aortic valve is the disease of the elderly. However, it has been proven that aortic stenosis is not only a consequence of the aging only. Histopathological tests and proofs have shown that calcinosis of the aortic valve is an active process which resembles development of atherosclerosis. Here we can see the relation of aortic stenosis with the age. And all we know that this is quite a tricky disease. It can remain silent for a long period, for decades. Then when symptoms occur, an urgent intervention can be necessary or could be necessary. Symptomatic aortic stenosis mortality is almost 50%. In 2 years, unless valvular stenosis is relieved by intervention, that means by or by surgery or by transcatheter aortic valve replacement. Meanwhile, asymptomatic patients must be constantly monitored and for the progression of aortic stenosis and occurrence of the clinical symptoms. This is a progressive disease, as you can see on this slide. But the progression is not linear in all cases. There are patients with a quite rapid progressions, patients with a slower progression, and patients with no progressions, and surprisingly, we can see some, but very rare patients even with regression of the disease. We have established guidelines for the severe aortic stenosis treatment. According to the European Society of Cardiology guidelines. But the problem is that all these guidelines are dealing with the invasive strategies, with the replacement of the valve, with either surgically or by TAVI procedures. All we know that aortic stenosis is a chronic progressive disease which very resembles with the development of atherosclerosis. Endothelial dysfunction, lipid infiltration, calcification, and ossification are evidence in both diseases. The same risk factors such as older age, male sex, smoking, elevated levels of lipids can be identified in both cases. That means, as you've seen in this slide, that patients with higher BMI or higher waist circumference are more prone to develop with the time an aortic stenosis. That's similar as with any atherosclerotic diseases. The pathognomonic pathomechanism of aortic stenosis is very similar to aortic atherosclerosis. And several histopathological studies have demonstrated changes compatible with chronic inflammation, with lipoprotein deposition, with activation of renin-angiotensin system. There are close similarities between coronary artery plaques, coronary artery disease, and the lesions or lesions of atherosclerosis. The aortic stenosis. The classification process also includes osteoblast-like activity and bone formation at the end stage aortic stenosis. In vitro and animal studies indicated that this might be a potentially modifiable process. We have several studies, usually with Mendelian randomization models, which demonstrate the importance of lipids in the development of degenerative aortic stenosis, at least in early stages. For instance, this study was conducted by Nazar Zadek and colleagues, demonstrated that each standard deviation increased in LDL cholesterol, total cholesterol, and triglycerides increases the risk of incident aortic stenosis by 60, 80, or 55%, respectively. In contrast, there was no evidence of causal association between plasma lipids and aortic regurgitation, as you see here, or mitral regurgitation. After adjustment for each lipid profile component through multivariable the results corroborated the association between LDL cholesterol and risk of aortic stenosis. These slides show the same results. Another very important study, according to my opinion, was conducted by a Danish group who, in the same year, proved in the same prestigious journal a role of triglycerides and remnant cholesterols in the evolution of the aortic stenosis. This study was published by Cardiology and colleagues and have found, following analysis of more than 100,000 patients of the Copenhagen General Population Study, that in the Danish general population, using again a Mendelian randomization, higher plasma triglycerides and remnant cholesterol were observationally and genetically associated with higher risk of aortic valve stenosis. These findings suggest that the high level of triglyceride-rich remnant lipoproteins might be one of the factors that facilitate the evolution of aortic valve stenosis. This is a very, very nice slide figure showing when, with the increase of the triglycerides and remnant cholesterol, the possibility, the incidence of the aortic valve stenosis increasing very sharply. The involvement of lipolysis and the fatty acid generation locally near the aortic valve, leading to an inflammatory cascade in initiation of calcification, are all mechanistic possibilities, see here, that arise from these genetic studies, Mendelian randomization. And these mechanisms could be corroborated in follow-up in vitro and in vivo studies. Resulting for future novel interventions given at early stage could reduce the potential tragic complications of valvular aortic stenosis, maybe in the future. These results, initial results, everybody was happy, and there were attempts to prove that with the use of the established lowering therapies such as the statins, fibrates, and ezetimibe, we can at least slow down the progression of the disease. However, the results were a little bit disappointing. First, these are the results of the SALTIRE study. Here, the investigators compared placebo with atorvastatin, and you see that there was no change in the aortic jet velocity and aortic valve calcium score in the two groups, despite that there was a significant decrease in serum LDL cholesterol level concentrations in the atorvastatin group, as it was expected. Another interesting study was a CS trial, which compared the simvastatin plus ezetimibe combination with placebo, and the results was the same, that despite the decrease of the serum cholesterol level, LDL cholesterol level, there was no change in the aortic jet velocity, no change in the progression of the aortic stenosis severity during the study period. There is a meta-analysis in the literature also that observing the intensive lipid lowering with studies, and we see that in fact if we pool the data with the C studies, the SALTIRE studies, and also adding the astronomer study, which compared the rosuvastatin with placebo, there were quite disappointing results. The investigators cannot observe any changes in mean aortic jet velocity, in peak gradient changes, in mean gradient, or in mean aortic valve areas after the therapeutic interventions. Another important player, let's say, can be the lipoprotein in the generation of, in the evolution of the aortic stenosis. The so-called lipoprotein A, the Lp(a), there are increasing evidence that suggests that the infiltration of lipoprotein into aortic valves play a crucial or central role in promoting inflammation here, which in turn might induce activation of osteogenetic processes. And histological analysis of expanded calcified aortic valves has revealed that the presence of several apoprotein, such as ApoB, ApoE, ApoA, apolipoprotein A, apolipoprotein a, could be found in these histopathologic species. Furthermore, there is an association between the level of oxidized LDL and the degree of inflammation and fibrocalcific remodeling. Indeed, we have also observations and studies. This is a almost 10-year-old studies from the JAMA showing that with the increase of lipoproteins and oxidized phospholipid levels, the chances and the progression rate of the aortic stenosis increases as well. These are some recent studies which show the same results, which confirm the same results, that lipids and especially lipoproteins can play a very important role in the evolution and in the progression of aortic valve disease. This is a very nice figure demonstrating the importance of the lipids and especially the lipoproteins level in the evolution and progression of cardiovascular diseases. We can see that calcific aortic valve stenosis is, let's say, an important target, can be an important target, and very closely associated with lipoprotein levels, especially with high levels of lipoproteins. Why were these therapies ineffective in these cases? This is a very nice editorial review paper published by Professor Tselepis in current atherosclerosis reports. We can see that statins, in fact, as a team, they usually applied medications do not have positive effects on plasma lipoprotein levels. In fact, maybe there could be also some increase despite decrease in LDL cholesterol and other parts of lipids. Maybe the newly used PCSK9 inhibitors can do some reduction, some beneficial effects in case of aortic stenosis. In fact, there is a secondary analysis of the Fourier trial which used the evolocumab as in patients, and they analyzed patients with elevated lipoprotein levels and aortic stenosis, and you see that evolocumab had favorable effects on patients with aortic stenosis and also the progressions of aortic stenosis. Patients with placebo has a greater chance for aortic stenotic events than patients with evolocumab, but this study was not exactly designed for this patients population. There is also some hope in the near future. We have maybe new targets for lipoprotein synthesis inhibition, such as antisense, oligonucleotides, or small interfering RNAs, which in animal models and in small studies prove that can decrease the lipoprotein synthesis in at least 80–90%. Some studies are already ongoing with these new drugs such as pelacarsen and olpasiran and etc. Finally, I would like also to mention some importance of the genetic associations with valvular calcification and aortic stenosis. We know that there are some genes associated with the presence of aortic valve calcium calcification and lipoproteins, which can also influence the fate of our patients. And that is why it is so important to use the Mendelian randomizations when we are trying to find out what is important and what is not so important in this patient population. Measuring lipoprotein A for cardiovascular disease prevention, in whom and when it is recommended that elevated lipoprotein is an independent causal risk factor for atherosclerotic cardiovascular disease and aortic valve stenosis. Many major international guidelines now recommend measuring lipoprotein at least once in all adults, and this is meaningful regardless of age, sex, comorbidities, or ethnicity to aid in risk stratification. And there are phase 3 trials of specific lipoprotein A lowering therapies, which are ongoing with the results expected in near future, hopefully. In conclusion, I would like just to summarize that degenerative aortic stenosis is a very frequent progressive disease. There are many risk factors which have been already identified regarding the evolution, regarding the progression of the disease. Lipids are perhaps one of the key actors. Genetic is very important. I think that there further research is needing, new therapies, there are ongoing studies, and there are some promising preliminary results, and maybe closer follow-up of patients with increased risk is warranted, we know. And how far, how close, we don't know. I think that we are still far, but maybe we are a little bit closer than we were 10 years ago. Thank you, and thank you for the invitation.
Okay, thank you very much for the very elegant and integrated approach to this evolving topic. Well, I think your recent thoughts expressed in the European Heart Journal, I believe, are of clinical significance because you reiterate the already known scenario of involvement of atherogenetic mechanism in the evolution of the aortic sclerosis. Actually, we have data a long time ago that in patients with familiar dyslipidemia, at a very young age, there are the early degenerative changes in the aortic valve, irrespectively of the dysplastic or non-dysplastic form of the aortic valve. And the interesting now has been raised due to the evolution of treatment of LPA itself with the new adjacent oligonucleotides. And I think another issue which is not properly organized in the early studies using statins in the C studies, Altair and Astronom, is that they studied patients with already established at least moderate to severe aortic stenosis. So if the valve has been already affected and the osteogenesis has taken place, it is difficult to reverse this osteogenetic approach. So I believe, Alpert, I don't know what's your opinion, that should we start earlier the intervention, especially in scenario with increased LPA, then probability-wise, we might end up with different evolution results in the aortic stenosis itself. What's your theme?
I completely agree. I think that all those studies mentioned were a little bit late studies. So as you mentioned, that it were already moderate and severe aortic stenosis, severe form of the disease. That means that we can, according to my opinion, if we want to treat the patients or want to stop the progression or want to stop the evolution of the disease, we have to start very early, and the knowledge of the genetic constellation is very important. Because if we know that this patient is prone to genetically determined for any type of aortic disease or atherosclerotic disease, we can start with early therapy, and that would be much more useful. Maybe also the statins could work in these phases. I'm not sure, because we don't have any evidences.
Well, I've organized in my mind a provocative statement that having the experience of the vulnerable plaques in atherosclerosis, it might be an equivalent pathophysiological substrate of vulnerable aortic valve to sclerosis and stenosis. And personally, when I'm dealing with a patient at the age of 35 to 40 years old, having an increased LPA and dysplastic aortic valve, without any obvious stenosis, I'm keen and very sensitive to start statins on him, even at the level of LDL, which is at the limits of near normal. So I'm very aggressive treating this scenario: dysplastic aortic valve, LPA, increased LPA, and the age of 40, 45, with an LDL of 120, 125.
Theoretically is perfect.
Okay. I think that we had the chance to provide us a very, very nice overview of this evolving issue. And we have to thank you once again to contribute to our meeting, which now has the age of almost 1/4 of a century. And we will to keep going with your contribution, probably on physical presence next year, Albert, and probably
George.
with new data.
Thank you, George. Thank you, and thank you all the Greek fans for this continuous support and the friendship.
Looking forward to meet you in Budapest in 2 weeks' time.
Okay.
All the